Good evening. I'm just going to, we've had a bit of feedback saying that some people are, there's a bit of a lag between them joining the webinar and us starting. So I'm just going to give it a minute or so, so that people can join and they're logged in. Just check. Nine participants at the moment. Hopefully you can hear me. I'll just wait a minute or so for people to join on and we'll get started. Just checking now. I'm just going to see people saying that there's a bit of a lag with the login. I'm just going to check that now. A couple of people saying that they can't log in. So if you can't log in, I think you just need to go through Eventbrite. I'm just going to see. Bear with me one second. Okay, that seems to be working. Okay. Give me just a moment and we'll get started. Okay, I'm going to get started in a moment. I just see it's just dealing with that. We've got 10 participants, so some people are being able to log in, and I think that's going up. It's gone on to 20 just now. Okay, we'll get started anyway, and here we go. It is recorded, so people that aren't able to make it or weren't able to log on will be able to watch this again anyway. Thank you for taking the time to join the webinar again. It's part 2 of bone grafting. I'm going to start with just a brief overview of guides, BioGuide in particular. There's, as I said before, a couple that I use. One is the BioGuide from Guy Schlick, who kindly forward this presentation, but also I do use a guide from Straumann, and I also use a guide from Zimmer Biomet. Personally, one of my favorite guides is the Jason membrane provided by Straumann. At the moment, they're getting the TGA, not because there's anything wrong with the guide, they just changed their source, so they have to go through that process. And we're hoping to get that back. It had a hiatus of a few months, but we're hoping to get that back by the end of the year. So without further ado, let's crack on. So we'll start with our guides, but I just want to have a short intro about a couple of things about people who've been asking how to join on and continue. Where do we go from here? Well, you know, what's next? You know that we're on Bobby Choker Education Facebook and the same for Instagram. So follow us on Facebook and like us. That would be great. We very much appreciate that. We're trying to put out these webinars for free, and for us to continue doing them, we need to form a big community. So the more people you share with, or any groups or Facebook groups that you're involved in, you can share with, please do so. It greatly helps. Follow us on Instagram as well. You can happily share the Instagram post or education posts on your Instagram. We would very much appreciate that too. Share with friends on community, because we are community based. We're trying to build a community. Bootcamp, people asked. So we've thrown around a few dates, and initially we were thinking, as I discussed last time, at the beginning of December, but seeing as we're just coming out of lockdown, a lot of people want to get on and crack on and do dentistry, basically, and I totally understand that. I am in the same boat as everybody else. So we've, by popular demand, moved it into next year, and as most people will be probably coming out of that into January and still working hard, we've decided to put it on the first week of Feb. That gives people plenty of time. The offer is still $595 for one person, and it's 12 hours CPD. Alternatively, if you bring a friend, it's still $595, so you can split that fee between you. So it pretty much ends up being just under $300 for 12 hours verifiable CPD, which I don't think you'll find anywhere else at that price. But also, it's a learning experience. You will learn quite a lot. You get to meet us, and you build some relationships. We are now about to launch the certification diploma and MSc for next year for 2022, which will be starting next July. So we are looking for applicants now. There are limited spaces only. We try and keep the group small, so there's almost one-to-one learning, and people can have an intensive course and get what they need from it. Just like the boot camps, we have planned the entire course so that there's takeaways so that you can instantly start placing implants once you've got through a certain amount of material, that is, and we can guide you in doing that. But the most important thing about our course is the fact that we give ongoing mentorship. That's probably one of the most important things. So a lot of the candidates that have attended past events come in, they're still able to plan and do everything with my guidance, and I give my one-to-one guidance through surgery too. We will be sending out to the database of people who have actually followed us and come along with the Facebook and Instagram, and also come to the webinars and sign up for webinars with content of that. And also take advantage of a unique invite. A few people have, and some people have been coming in. Thank you, Robert, AR, and Lindsay, who have come in and sort of been able to discuss where they want to go with their implant career, how to get there, and also how to start up and maintain a successful practice. You know, it's not just about implants, it's about the actual practice of implants and the business of implants and your practice and all our systems and everything else that we've spent a lot of time organizing. They've had access to, which I hope can be of great benefit to you. The email, if you want to contact us for any reason, whatever it is, experience, courses, or anything else, is at the bottom there, education@drbobbychoker.com.au. And you can just pick up the phone and give us a call. If you do give us a call, the person that coordinates this is Millie Robinson. You can actually see in the picture there on my right. And if you contact her with anything that you need to know, or anything you want to do, or help that you need, please do so. And we're happy to help you treatment plan things and all the way through. There is no cost for this, and that is unusual, because usually there is a clinical fee for people coming in and assisting, observing, and everything else. And we've actually got rid of that completely so that you can get jump started in your implant career. Okay, let's get into it today. Without further ado, bio guide. As I said, I use various membranes, but we're just going to go through a bit of this. There are some other slides that I have to do with guides, which we won't be going into depth in here, because I want to give you synopsis, because a lot of the applications are very similar, but just that they've been adapted to either NEPA guides or smaller guides for filling single tooth spaces. But I will talk about BioGuide, and that tends to cover most of it, because what I really want to get into today is some application. Okay, people want to know techniques. So it's collagen membrane used in dental guided bone regeneration and guided tissue regeneration. It's natural collagen, porcine. It's basically processed and cleaned so you avoid any immunogenic reactions. There's a porous surface facing bone and a dense surface facing soft tissue. Not all membranes have this. BioGuide has this particular feature, and there's a few others. And when you're using it, you need to know which side is which, and that's fairly easy to see. because when you look at the membrane, you will see a shinier side, and the other side a porous side. There's no chemical alterations, no artificial cross-linking either. So it tends to use as a barrier membrane for regeneration of bone defects. And the collagen is important, as I discussed before. You're going to get much better results with bone grafting by using a membrane, because it's indicated in that actual procedure. You don't get soft tissue ingrowth, and you can stabilize by using sutures or tacks the actual membrane. The more stable that your graft is, the more likely you are to get a good graft at the end of it. And it's also used to enhance soft tissue formation. So it's using GBR, immediate and delayed augmentation around implants, in extraction sockets, reconstruction of the alveolar ridge, which will go into some technique today, and filling of bone defects and cleft closure surgeries, which we're not involved with. I have been involved to some extent with the assistance, or actually my assistance to the main surgeon as a max fat surgeon. It's not something I suggest you get into. It's all, as I said, it's indicated for augmentation around implants placed in immediate extraction sockets, implants placed in delayed extraction sockets, localized ridge augmentation for later implantation. That's predominantly probably where I tend to use it. Although extraction sockets as well, immediate. Alveolar ridge construction for prosthetic treatment and filling of bone defects, root resection, cystectomy, removal of retained teeth. A lot of these cases are not so much cystectomy, it's up to you what you bring into your practice. Root resection maybe, but I usually sort of refer that type of cystectomy out. It's not to say that I haven't done it in the past, and I see myself fairly competent doing it. It's not something that I enjoy doing anymore, so I tend to do what I like doing. And removal of retained teeth is probably the main place. Dehiscence defects is another one. We'll go into what type of defects and how they're treated. And guided tissue regeneration procedures and periodontal defects. Now, I have used this for periodontal defects. I don't usually get into periodontology. I usually refer to a specialist periodontist, but where we have an implant and it's a possibility within my hands and my capability and my scope of practice to augment a defect that's next to an implant or something that we're placing, we have used it. So you've got three sizes basically. The 13 by 25 is really used for single implants or single defects that you're storing. The 25 to 35, again for single ones where you've got a larger gap, maybe a molar gap or a larger defect, and the 30 by 40 is usually for like 2 to 3 teeth that we're basically grafting. Sometimes, depending on the situation, I will use the 30 by 40 for a single defect where I'm trying to double layer the membrane. There's various combination packages and that you can get hold of as well within the Guide library of guides. It usually comes like this, and there you can see the smooth side, which is fairly obvious. It does actually have a little mark if you look on that diagram on the bottom left of that membrane. On the shiny side, you can see the up mark, so it's fairly obvious to see where it is. And then you've got the porous side, which is face down, and the shiny side, tissue side. That's the icon they use, and again, they use a blister pack system, which is easy to do. If you come in and see us, as I said, taking advantage of the unique invite, you'll be able to see us use this all the time. We do a lot of grafting, mainly because of my view is that if you want to get an ideal result, you want to take it back to nature and the way it was. Now, that's not always possible, and quite often we're just mimicking that. But if you can take the bone back to where it was, you can place the implant in the ideal position where the tooth is meant to be, and therefore the adjacent teeth are in line, and it also helps you with platform switching and emergence profiles, and ultimately the restoration being in the right place and being screw retained, because you don't have to cement with an odd angled implant, but also then affects the occlusion and the restoration and the longevity of the implant. So if you look at it that way, it's quite important. Okay, so as we said, we've been through all of this and the sizes. Again, that there's a compressed version as well that they get that you can also use. But what I want to do after this is jump into, rather than the perio part, we're going to jump straight over to the indications, because I'm sure that you've heard enough about membranes, and we're going to go on with the membrane part of things. Okay, so application in therapeutic areas. It's pretty much something that you can get for every situation. Minor bone augmentation is probably what you will start with, especially if you are a novice. I don't think soft tissue regeneration is very difficult for someone who's starting out to do. It does need a bit of technical information and it requires some skills, but I think with the first two, they're fairly easy to do. The extraction soft pit management is also easy to do, but you need to just be able to classify the type of defect. And not all defects respond to the simple sort of membrane and covering the socket type of approach. Periodontal defects we've discussed before. As I said, I don't get involved too much in there, but sinus floor elevation, major bone augmentation, peri-implantitis we discussed last time. I don't try and get into too much either. I'll come back to that, but the sinus floor elevation, major bone augmentation, is sort of more in the advanced to complicated section with SAC qualification of the events and categorization. And it's not something that I suggest that you approach without having good guidance. You need to have good knowledge, evidence-based knowledge on what works and what doesn't. You need to have some form of typodont application to it, because you need to see that that you're able to do it on a model first. And then my view is, when you're doing things like this, even let's say someone's starting minor bone augmentation, you know, as I said, come into the practice, come and see us, because the stages that I would suggest that you approach this in is, one, the theory. So you need to have evidence-based good learning and theory. Very important, university-based, and everything even we do in these smaller webinars comes and drawn from the stuff we present in the certification diploma MSc. Secondly, you then need to be able to practice the application physically into a typodont situation, where whether it's pig's jaw or models, so that you're able to use that and know the technique, and then basically apply that in a real sense in a patient. My view is that when you're then jumping from the typodont to a real situation, there's a number of things that you counter that you haven't thought about. And it's a good idea at that stage, before you jump on yourself, one, to come and watch somebody else do it and do it properly. And then secondly, you know, if you then want that person to assist, which is the role of a good mentor, that's what should happen. Because when I was learning, I was assisting in procedures numerous times before I actually went and did the procedure myself. And I was lucky enough to have a mentor, as do you, if you take up that offer, where they can actually sit with you, assist you, and guide you through the whole process. And once you've got that down for a few different types of complication and a few different types of situation, you'll find that it becomes second nature. You know, if you look back to when you hadn't given a local, you know, how sort of timid and scary it was, or you hadn't cut a prep, or actually a filling, compared to, and then it's become second nature. It's the easiest thing you can do, compared to when you had no knowledge about it. And that's all it's about. There is nothing special about me whatsoever. All it is that I've done this again and again, and I've been through a learning process. So I try and do things properly, and that's how we run things up in practice. So therapeutic areas, you've got minor bone augmentation, soft tissue regeneration, major bone augmentation, extraction soft pit management, sinus floor elevation, and the other two I've just discussed before that I don't get involved in. With the peri-implantitis, we did discuss this last time. In my hands, it may be better in yours or other people, so please let me know if you use something for peri-implantitis where you're getting alveoplasty in your building bone back up, but I found that whenever we've attempted it, things usually get worse, not even stabilized, but we discussed that last time. And if you're unsure about that, please go to our YouTube links, and you can watch the last bone grafting part 1, and I discussed that. So probably the most common one is extraction socket management. This is the one that I suppose that comes across most often, and something that, if you know how to do, is actually quite fun to do. Some cases where, with the patient permission and consent, where patients are not completely enrolled into having an implant, they may be enrolled into the fact that they want to preserve the ridge and give them that option later. And if I was starting out, I'd probably try and do it so that it's at pretty much cost price to what it costs you, making it very feasible for the patient. And if they're compliant and give you consent, you can start doing some of these sockets. Now, even if they don't come into you coming back and putting an implant in there, it will at least give you a better ridge, a better soft tissue, so that if you even place a bridge, or say it will give you a better gingival aesthetic line, and give you a better outcome. So that's the alveolar ridge. So the left side of the image shows an atrophic ridge with no ridge preservation, and the right shows a preserved alveolar ridge. So this is what you can see, and this is a typical way that particularly the maxilla resolves. The mandible does resolve in this manner as well, and that can become a bit more complicated, which we'll go into a bit later. But ultimately, you want to get that bulk of bone, but not only the bone, tissue too. And quite often you can use a graft, but my preference or go-to is if there's available tissue that I can get, then I'd rather use the patient's tissue. So there's the alveolus. There's the top view of a minimally damaged alveolus, and then there's a proper defect. Now that defect looks sort of minimal, and to be honest, you could probably treat that the same way almost as the two above, particularly the one above, which is a minimally damaged alveolus. But you need to be able to see whether the defect is just towards the coronal part, if it goes all the way down one side, if it actually goes through to the other side. So there's type 1 and type 2 as mentioned. The other side of the defect would be a type 3. And type 4 is the through and through, where it's all the way through. So you're building the entire height of the alveolar ridge. So you're putting BIOS collagen into the alveolus with preserved buccal bone wall. Okay. You're then going to use a mucograft to plug the actual hole. Now, there's a few different ways that you can do this. My usual way is, number one, when you've got a socket and you're preserving a socket, you want to correct the socket extensively. You want to make sure that all the actual tissue, periodontal fibers, any granulation tissue is removed from the area. I usually then irrigate heavily with saline. It also allows you with good illuminations of loops to see anything you left behind. An ideal way of doing this, which is what we do at our practice after we've done that, is that we use a piezo to make sure that socket's super clean. Now, this sounds like you're going overboard, but it's not, and it doesn't take much time. And if you don't have a piezo, just work harder in getting the socket nice and clean. You can also usually see with flushing out with a saline where you left it behind, because it momentarily stops bleeding, is clear, so you can see things. Now here they're using a mucograft. Now that's not always the way we tend to do things. If I'm doing that, I will still use a barrier membrane. And what I tend to do is, once the extraction socket is there and we've cleaned that out, the next stage would be to basically relieve the actual tissue from the actual bone around it, so you can slide the membrane into it, which you see on the bottom, the last slide at the bottom of the picture there. You want to set up your membrane first, because trying to get membrane in after you've been bone grafting gets quite messy. So if you set that up in advance, things are much easier, because you can add the bone. In this case, they're using the BIOS collagen as a plug. you could be using BIOS, the smaller granule size, and then you want to actually get closure. With some of the micrografts, you don't need to actually you just need to plug the hole, and then transitions through granulation into tissue. But one of the ways that I like doing this is basically to cut a pedicle flap. So I basically cut a shape from the palate side and then swing that over and cover it over, because that will still have a blood supply, and there's nothing better than the patient's own tissue. There you've got the immediate implant placement. Again, immediate implants, I would say, is more of an advanced thing. It's not something I would suggest that people do when they're starting out or have a limited amount of knowledge, experience. The main reason being there's probably about 12 to 14 criteria we go through to decide whether or not an implant should or shouldn't be immediately placed. And we cover this extensively in the boot camp. So, get yourself there. This gives you a lot of knowledge as to when and when not to do things. Reason being, immediate implants are more complicated than you think, and there's a number of factors that you need to consider. Here you can see where they're placing an immediate implant. The rule of thumb for placing immediates, just so you know, if you're at stage for me, is that if the gap around the implant is less than 2 millimeters and you've got good blood flow and there's bleeding, and it forms a clot around it, you'll find that usually fills in with bone as long as you treat everything beyond that. It's not a simple case of just popping the implant in. There is a bit more involved in there. Again, we do cover that at boot camp, so you'll get to know about that. But if it's greater than 2 millimeters, you do need to augment the site, because what you'll then end up doing is have an implant, but the bone will resorb. You also need to make sure that the implant has primary stability. So you want to be drilling into fresh bone and you have that implant locked in with good stability, minimum of 35 Newton centimeters. The classic procedure for immediate replacements is the fact that you want to have an implant to fit as much of the socket as you can. So it's gripping as many walls as it can. So it's actually engaging with the bone. And usually we will try and go 3 millimeters beyond the length or the depth of the socket. So this is basically the suturing of the micrograft on top. There's multiple smaller sutures, or they're using almost sort of like a closing suture in a cross form. I prefer to use the single interrupted sutures to really get it firm. With the cross suture, what can happen when patients are rinsing or finding postoperative instructions is you get movement of that micrograft if it hasn't really adhered to the tissue. If you actually lock that into place quite tightly, that can suffice, but it's just like to be dealt with razors. Okay, so look, you can see the difference. If you're using BIOS collagen or a graft, and a micrograft, let's say it's just not graft, it's just a graft, and that's a seal after 6 months. And then you see the spontaneous healing after 6 months with no ridge preservation. And the one on the left is probably still a utopian result, because if you don't preserve the ridge, it's usually much worse than that. And those bits that it's removing or missing, the buccal and lingual, particularly, diminishes the diameter of the implant you can place, because you need at least 1 millimeter. I prefer 2 as a barrel around the implant. Also, you losing the gingival aesthetic height. And as I've said before, soft tissue is the issue, but bone sets the tone. So bone is ultimately what you need to be able to control. So this is an intact alveolus after tooth extraction. There's a preserved ridge and then a non-preserved ridge. The problem with the non-preserved ridge, or you say, look, it's lost a bit of bone, still place an implant. Yes, that is true. But if you look at the middle slide, you can see you've got a very wide base, very high up to start with. With the one below, if you're either compromising placing a narrow implant, because you've got basically a peak like a hill, and quite often if that isn't significant in terms of the height drop, you can flatten that off and you can basically turn that into the middle slide. but you've obviously got some bone loss, ideally you want to have that preserved ridge, because you want to place the implant in an ideal place so that you can restore it ideally in the occlusion ideal, so it has longevity. But also you want to try and have forces go actually down the implant. Now look, when I place them, that's not often possible. For example, anteriors, or you have a ridge like that, but the patient has declined bone grafting, you need to discuss with them the compromises that they're making. So it's not always possible, but you want to try and achieve whatever you can in that manner. So this is a tooth with a buccal bone defect. You can probe around it and see basically around a tooth which is irrational to treat, and the probing depth. Now this is easy to do if you don't have access to CBCT, and it's probably the easiest way to do it. In most of these cases where they have that and they have granulated tissue and inflammation, although it just seems like you can sort of pretty much put a probe down there, you know, if it's easy to do, you have to be very gentle, but I would suggest that you numb the patient up, use some anesthetic to assess that. Ideally, my view is that you should always have a CBCT, and that doesn't matter if it's a media, a single implant, it could be a large block of bone in the back of the mouth where you've got a platform like the preserved ridge we discussed before. I still think you need a CBCT because you can come across things that you don't understand, can't see, and you can use a reference point from there to place the implant. Here, the tooth is removed. You can see the socket there. Now, with this, as I said, you want to de-epithelialize the margin and the actual socket. They're here using a drill, and that's fine. You've got to be careful. It isn't just cutting away the lovely bone that you need. My preferred technique is to correct the site and to piezo, and then place the implant. In this particular case, if you look down at the bottom, I wouldn't place the implant along the line of the socket. I would actually angle the implant more towards the middle of the alveolus and place the implant there. Sometimes we will start it with an extreme angle that's actually going towards a palate, start it off that way, and then turn and move upwards. And what that does, that the bone that's above it will then be pushed towards a buccal, and you get more bone in that area. It won't fill a defect like that, so you would need to augment that, particularly if it's anterior. There you can see where they're measuring of the alveolus, and then they're basically using they're going to use bias collagen, but the bio guide there, and it's been cut to shape. You want to be able to cover the defect. If you're cutting this away, you know, my view is why waste that guide, because you can't use it in anyone else, and I usually double membrane. That doesn't mean that, you know, you don't secure the second membrane. What I tend to do, place the membrane, do the graft, and put both membranes as almost like a single membrane over each other, tucked in very neatly, and then I'll secure the membrane. For a single tooth like this, depending on the defect, if it's a simple defect, a 5/0 suture will suffice in a cross figuration like we discussed for the Nico graft within the inside of the flap internally to really secure the membrane, and then usually a 3/0 to close the flap. In most of these cases, whether it's a single implant or not, you will probably need to have some periosteal relieving incision, so you need to know how to be able to do those. Here you can see they are basically using the membrane with the two sides, with the upside where it should be, and then they're trimming the collagen, bias collagen, and adding saline. As I said before, we prefer to use the patient's blood to wet it, but you obviously want to cut it before you wet it. Okay, there it's being plugged into place. And in this case, they're not placing the implant straight away, so that it's basically filling the entire socket. One of the things that a number of people ask is like, how do I sort of pack it and put pressure? No, you want gentle pressure. You want to be able to fill the socket without compressing that membrane too much. You want it just to fill the hole with as little pressure as you can have. And then you basically, because you place your membrane in advance, it's easy for you to then move on and tuck the membrane onto the other side. They use a simple cross suture to close a wound. My suggestion with this is to make sure you actually have soft tissue covering the socket. I think that is sort of the best way forward with those. Okay, that then resorbs, and then you've got when you've had no ridge preservation, as I said, you've got that buccal defect. You do get some palatal, but you tend to get less of the palatal defect because, as you know, most of the blood supply coming from the buccal to that area, and that's what causes that large defect. So, you know, in most cases, you want to try and preserve the buccal bone, and also, where possible, and you've got a good CBCT, if you don't have to lift the buccal side, if you're not grafting, you're placing straight away, and there's a decent size implant so that you've got less than 2 millimeters, and you don't have to augment down the socket, and you don't need a membrane. That's probably the better way to go. And so with no ridge preservation form, you can see the actual defect in the way that it forms. There's one with it actually preserved. And as we discussed before, you've got sort of an ideal situation there to be placing an implant. And in the same way, even if you're placing a bridge, augmenting the area so you get a better gingival aesthetic line and there's no recession on adjacent teeth too, is not a bad way to go. So it's not just about implants. I personally don't like doing bridges. They need to see a last resort because the patient is medically compromised and therefore I can't place an implant, and that's where we sort of tend to do a bridge. But as an option, we tend not to do them at our surgery. We prefer to have an implant. I'd rather a patient had a denture over a bridge, largely because the statistics show, I think on average between 8 and 14 years, that one or both of the abutments have complications, whether that's root canal treatment, failure, so you're linking the problem rather than dealing with it. Even if the teeth adjacent to the gap require crowns, that's not a direct indication for a bridge for me. I would still rather put 2 crowns and another restoration in the middle, and if it's not an implant, ideally it would be. So minor bone augmentation. This is a situation where you've got bone for the implant that we've seen before, but there's still a buccal defect, sufficient for it to actually have a successful implant placement with 1 millimeter bone all the way along. But for you to get the ideal aesthetics, as I said before, you want to try and put things back to the way that they were before you have the resorption, ideally. And this is a good way to do it. In these situations where it's a minor defect, we're adding bone to the buccal side. In these cases, I don't tend to use a membrane, a suture to secure the membrane. I would tend to go towards a tack, simply because it's just a far more secure way of securing the membrane in that area. You want that buccal bone. Quite often, if there's a severe defect, we will first of all conduct the bone grafting. We'll then get the patient back and do some soft tissue grafting, because the bone with a very large defect can sometimes be insufficient. If it is sufficient, that's fine. You want good keratinized tissue around it. And what we do, we lift almost an identical fat where it's been augmented and put connective tissue into the area to bulk the area. Here you can see where they placed it. And there's a fenestration, and this is where you've had resorbed bone and you've decided not to augment the area. And sometimes, look, we can try and place the implant, you get a fenestration, and you just need to know what to do with it. You're not always as predictable as just looking at the X-ray or CBCT, guiding it, and you think it's going to be within the bone. And when I'm placing into an area of defect, I always like to place it flat so I can actually see what is going on there. Bone is clearly visible, and then you can work around that. This is not like alveoplasty, so when you've got a fresh site and you place the implant, you can augment at the same time. In this situation, to be sure, I would put a base of autogenous bone over the implant, because I prefer to have the patient's bone around the implant, almost like a layer, and then use bone graft over the top of that, of course, you still need to use a membrane. So this is an uneventful healing of the soft tissue that you can see, and the junction between it, and there's the vascularization. And the other part showing without using the use of a membrane, bacterial contamination. That's not to say that you can, you know, when you do use a membrane, as I showed in this one's got a membrane, you can't get contamination. You can. How do we know? It's fairly obvious. It does not smell very good. There's lots of inflammation there, and you can usually patient complaining of it being uncomfortable for a long time. Just so you know, as a rule of thumb, with these grafts, you just have to get used to the fact and be able to manage pharmacologically and other ways to basically reduce the after effects of grafting. Grafting is not a nice procedure. Patients are uncomfortable afterwards, and you need to have a set protocol to diminish and reduce the complications, particularly pain. Swelling can quite often occur. If you look at, you know, I think I showed in the last webinar, the one before, you know, where we're doing larger procedures, you know, for example, if we're doing upper full mouth rehabilitation, we're removing all the teeth, we're correcting everything, cleaning out everything, we're doing alveolectomies, replacing 4, 6, or even 8 implants. In some of those cases, we have to do a bilateral simultaneous sinus lift. That's a lot for the patient to go through. That's obviously why it's done the sedation. And when something's that complicated, we tend not to do upper and lower together, because if it's simple, we prefer to do that because it's simple. But the patients swell; they swell a lot. And in the bigger procedures, they really swell. You know, quite often I see patients with the swelling so big that their eyes close up. We need to warn them of that. We get bruising that can track down their face and towards the mediastinum. We need to be careful of that. But they all get swelling. With a membrane like that, it's infected. You need to just remove it as quickly as possible. Clean the area out. You just basically have to have damage control. You can always come back to it. Leaving it and pushing it to somewhere where it's not going to go is not a good idea. That is also why I quite like to close the area of the patient's tissue and make sure that we've got complete closure, which is tension-free. This is bone formation, just showing the bone formation at 2 weeks, 6 weeks, and 12 weeks. It's mainly showing that the trabecular spaces have a maturation, and there's lamellar bone that starts to be formed. There's 2 studies there, Schwartz et al. And Jarosz et al. The Schwartz one in particular, I quite like. It's a good study to go away and have a look at and read. If you can't find that study, don't have access to it, because a lot of these studies require you to have a subscription, which we have through the university. Please let me know. I'm more than happy to forward any studies you see onto you for you to view and see. Okay, soft tissue generation, just as important. Going on. In most cases, people tend to forget about the soft tissue. I tend to try and treat anything posterior just like an anterior implant. You want to try and be an idealist if you want to get really good results, and I think that's the way that you should basically carve your career. Then that's the way that you should embrace these situations. You want to take it to the highest level you can within your scope practice, and if it's out your scope practice, come and learn how to do it properly. So, soft tissue regeneration. Discuss a bit of this. Basically, there's a natural healthy mucogingival line. There's a shifted mucogingival line with reduced keratinized tissue. And that's the last one shows mucogingival line that's reduced keratinized tissue and gingival recession as well. And that's obviously going into the mucosal part of the tissue. Keratinized tissue is important around implants, and there have been some recent studies to show that it is not essential, contrary to popular belief. I have been through a number of these studies. I don't think it's conclusive proof, and unfortunately, I'm going to quote what all these studies to say as a get out, which it requires further investigation. However, I still prefer to have that keratinized tissue. If you've had patients where you've had everything perfect and you've gone to the nth degree with all this bone grafting, coming back, planning the crown, having good platform switching, emergence profiles, good stability, you've got a beautifully integrated implant, but you haven't got that keratinized tissue around it. I find patients have constant problems with it. And the problems tend to look a bit like when you have a crown or restoration that's approaching the biological zone. So you have that red inflammation and constant red line. More importantly, they tend to get the symptoms that are a bit like periimplantitis. Periimplantitis usually presents itself as a patient constantly feeling pain around the implant after it's integrated and you restored it. And that's usually bacteria at work in that area. So ideally, you want to try and get keratinized tissue. Okay, there's a healthy gingiva recession and a larger gingival recession. In these cases, again, you quite often see people getting connective tissue and weaving it between the papilla to basically treat gingival recession. However, my view is that if you're not going to get the bone there, I find in most of these cases, the success rate of these, I think, is quite low. It's sort of 13% or thereabouts. I don't quote me on that directly. I can go back and look. It's a long time since I've looked at that literature, but it is low. So you have to warn the patient that, immediately that's the success rate, and then long term. Ideally, in these situations, I'd probably want to debride the root, clean it really thoroughly, and then augment around the root. And in these cases, I would use Emdogain and prep. They almost come together, and graft the area. I then want to come back and see what soft tissue situation I have, and then adjust that accordingly. We may have an ideal one and it's followed suit. That doesn't happen that often, and quite often you need to cut some soft tissue grafting. Here is basically the flap that is designed. I tend to use this type of flap. You can use the flap at the bottom as well, which is around the papillae. The main thing is not to go through the papillae. We'll talk about flap design if we come down to the boot camp and go through all types of flap design for all situations, because there's only a limited number, probably about 5 or 6 that you would come across really. Well, a few more if you're doing more complicated procedures, but you probably need to know 3 or 4 if you're going from basic to intermediate. You avoid the papillae, you maintain that you don't want recession in that area and kill that off, and you can see the basic flap that they've raised there, and they then are using a mucograft to fill that. Now that's an easy way of doing things. As I said, there's sort of mixed results. It depends on the situation. Larger defects and more complicated procedures, I usually would prefer to use the patient's connective tissue. However, in certain situations, we've done that and reduced the actual defect and turned something that's complicated into a simple case. We then augment or advanced case at least, simple, advanced, and complex in that order. And then using a mucograft technique, so it's taking more than one trying to get the actual soft tissue in place. Okay, this is a type of defect on the lower that I see quite often, and I'm sure you do, that recession around the lower incisors. Again, in this type of flap design is slightly different. As you can see, there's a horizontal incision at the level of the crown of the tooth and the point at which it meets the root. And in this case, they're using fibro guides. These are quite effective. I use these time and time again. You need to check before you do any of this to see whether the tooth is vital, and you also need to warn the patient of devitalization. Excuse me. And it may be a case that if it becomes devitalized but you have good bone around it, you may then need to subsequently do a root canal treatment and a crown. But you restore the gingival aesthetic line and the anatomy and biology of the area. This is the most common place for connective tissue grafts. Okay, so I'm going to talk a little bit about this because somebody did actually send me an email about this a couple of weeks ago because they were talking about soft tissue, and that's why there's a large section to this. It's not just a set presentation, so I've included all these out, put these into presentations specifically. The palate is still where I go to for connective tissue. I want a few things. One, it takes quite a bit of skill to get a good connective tissue graft and for you not to damage the donor site significantly. Two, regardless of what you do, it is painful for the patient. It's not very nice. No matter how well or neatly you do it and stitch up, patients will ultimately form sort of a large ulcer. One of the ways that we combat this is to make them almost like a suck down that covers the palate, basically, is what it is. Because we 3D print, we will then sort of 3D print beforehand, have that ready. And then what they can do is they can use certain topical solutions on the actual site and put that over it. Because quite often having a barrier against the outer against the outside stops some of the symptoms. Now they don't want to have that the whole time because the tissue does need to breathe and it needs to heal, but that's one of the ways that we combat that. If you have a case like that and you'd like to see it, or you contact us as soon as one of those comes up, I can show you. I try not to use connective tissue unless I have to, and as I say, it's a major defect. There's no other way around it, but quite often procedures I do are larger procedures, so there's connective tissue around that I can harvest and put into that area. Okay, that's a inflamed gum around an implant. They've done a split thickness flap there. You need to know how to be able to use that, do that, and where it is used. And in this case, what's happened, they've used a mucus graft to cover it. It's left exposed, this one, for an open healing. It's not ideally the way that I like to do things. I think it has a higher risk factor. But if things go well and the patient is compliant and they follow instructions, the mucus graft is actually a fantastic thing to use. I use the Geistic one. I actually use the Straumann one. It depends on the defect and it depends on the handling. I do like both of them. And there's a healthy gingiva. You have to remember there's not always that you get that. That's the ideal that you are aiming for. Okay, so buccal concavity. You want to, when you start that, you want to measure the size of the defect so that you know that what you're going to use in the fibro guide, and it's placed onto the soft tissue deficiency around the implant. I again prefer, this is to gain soft tissue volume around implants, as we discussed, and I still prefer to graft and do all the bony work and then the soft tissue work and then come back to that rather than simultaneously doing this. That's not always true. Quite often that's what I have to do because that's what the situation demands. But if you want to keep things simple, that's a better way to do it. A basic giveaway that I can give you, which may not mean much to you now, but if you get into this, you will realize what a diamond this is. And someone said to me before, is that if you reduce the number of complications that can occur, you're walking on a wide road. If something happens, it's very easy for you to bring it back and deal with that complication. If you're doing so many things at once and hoping everything goes right, you're pretty much walking on a tightrope. And one thing goes particularly wrong, you fall off that tightrope. So, even now, regardless of how experienced you are or not, that is the way that I suggest you approach these things. There's tension for the wound closure, and that's the outcome after suture removal. One of the techniques, and this works quite well, is sorry, let's get rid of that. Is a strip technology which has become popularized by Esteban Urban for the gain of keratinized tissue. So you basically place a strip of free gingival graft to suture to the equal part of the wound bed, the predominantly Geistic mucus graft, and sutured into the wound bed and left uncovered open bleeding. In most of these cases, to get keratinized tissue, what we tend to do is use what's known as a ethically repositioned keratinized tissue graft. So we'll make a incision at the top, lift the flap, and that flap will be then sutured to the base of the incision rather than the coronal incision. Again, it's not particularly comfortable afterwards, and that tissue then basically forms a wound healing by second intention, and it then also tends to ulcerate, be sore, but eventually you get good granulation of tissue around that. But this is another way of doing it. So we're going to just come to ridge augmentation we went through last time. So we're just going to go through the last bit, and I'm going to just touch on sinus floor elevation. Now this is, regardless of what you're told by whatever company is selling you whatever, like you can basically use a pneumatic device, you can do a transalveolar easily, you can use a kit to raise in a transalveolar approach. That means rather than putting a lateral window, you're going through the actual osteotomy where you're going to place the implant up to the sinus and then pushing that sinus membrane up so you can put bone in there and create more bone between and put an implant of a decent size in there. These all carry a fair amount of risk, and you have to remember in these situations, one of the worst things that can happen is that you push the implant or biomaterial into the sinus. And if you've had a patient where that's happened, and I have, as I said, I like to talk about things that have gone wrong for me, because that's where we learn. And it doesn't all go right for me. If anybody tells you they do, then you need to go and find a different mentor, because you're not going to learn anything. If that is particularly biomaterial, if that gets infected, that's a nightmare. It's horrible for the patient. If it's an implant and you push that implant into the sinus, you don't want to go searching for it. You then need to refer to a max back surgeon who will have to go in there, perforate the membrane, retrieve the implant, and Weber Wang is my go-to who I refer to for our max back stuff. And they have some specialist equipment, almost like a camera probe with an end piece that almost looks like one of those things you get at a fairground for trying to win a toy out of those glass boxes, and it will grab the implant and they drag that back through. But then you also need to be able to repair a large hole in the membrane, and quite often that is done by getting fatty tissue from the area, stretching it over and forming a pseudo membrane. It's not about just simple lifting, it's about what can go wrong. We teach in the first year cert bone grafting to a more advanced level, as well as treatment planning, guide formation, placement of implants in the easier areas, particularly guided, but we also teach non-guided, so I think you should know both. But in the second year, we go into sinus lifting because it's a subject by itself, and we spend a good 3 to 4 days going through all the theory, typodont, and then what I usually students will find cases, or I have cases, so they can come and assist and actually get themselves involved, and that's what I would suggest you do. It's not something to be attempted because you've learned something on a webinar or anything else that requires any of this. I suggest that for, but particularly this in particular. Okay, so you've got an illustration of an implant placed in the alveolar crest below the sinus cavity. That's absolutely fine. Where we're limited in terms of the amount of bone we have. So, for example, if that situation was all the way up to sinus was the smallest implant I could place is all I could do was a 6mm implant, and I'm getting very close to sinus. Ideally, I'd like to lift the sinus and place an 8mm implant. If I've got a lot of width, then I place a larger diameter because it's surface area, it's not just length, so you can increase the diameter. But if I'm getting close to that, I will quite often use one of the finest prep drills that they have, and the finest one we have is a 1.5mm, it's like a needle drill. I'll drill up to the sinus, and actually you can feel as you get sinus the bone, and that comes with experience. It's a lot harder, and you can feel when the drill stops a bit, and then you actually, to confirm that, punch through, and you can actually feel it punch through. We'll then use radiography to see and confirm that, and then we'll work backwards from there. Second is a schematic illustration of an implant protruding the sinus cavity due to lack of bone width. This is not what you want. In certain situations, you can have implant placement and simultaneous sinus floor elevation. Now, in that illustration, as you see, what you need coronally is to have a decent amount of bone so it really grips that implant, and you want to be almost trying to achieve, funny enough, primary stability. Because it's a tapered implant that I use, the top of the implant is wider, so as you're going in, it's pushing and pushing that bone. We obviously prepare that in a specific way, so there's under preparation, there's a few other things that we do, so it really grips up that neck so that patient implant is stable and it has doesn't have a high chance of going into the sinus. But what we would do before that is to actually lift the sinus membrane, place the implant, and then I prefer to put membrane around that sinus cavity, fill that with bone, and then in this case where they've sort of left it as a tissue level implant, so you can see when they placed it, you still have that top part of the implant through. I would tend not to do that. My preference is to have a bone level implant to put the cover screw on that and cover the whole thing over. Because what I don't want is pressure onto that implant, it moving, or especially being pushed into that graft or the sinus cavity post-operatively. And out of occlusion doesn't exist, because something like that, as soon as you put a bolus in the mouth, if it's in contact with that, it's back into occlusion. This is basically a lateral approach with a lateral window. The vast majority of sinus lifts that are done just with a surgical round burr using sinus lifting instruments, manual ones, they found that a large number of them, in the 40s percentages, have micro or perforations. And quite often the area is bleeding and it's tucked around things, etc. You can't see these perforations. Not a good situation to be in, because there's multiple complications you get of that. Your graft won't, you won't get a graft that you wanted to place things in, and you can get communication into sinus or antral fistulas, etc. So we always use piezo, and that's far reduced. I think it's in the 12 to 16% of a micro perforation. And the perforations are, obviously a lot smaller. If that does happen, we'll try to be as careful as possible. And you need to be able to assess the anatomy of that sinus. You need to also avoid one particular blood vessel that runs quite often towards the back of the sinus, sometimes across the front of the sinus within the membrane. So you really don't want to perforate that when you're sinus lifting. And there you can see lateral window approach. That makes it look like you can poke things through a tiny window. I'll tell you now, you need a decent enough window to have access, and sometimes you create a window that's bigger than you think you need. And they're using BioOS and BioCar, a guide to cover the lateral sinus window. I prefer in these areas, because you'll find that if you're doing with a single implant, we're trying to use a transalveolar approach. But if it's bigger than that, or it's a molar where we're doing more than that, it's a lateral window, and it tends to use quite a bit of bone. That bone that you can see there is probably between 2, 3, and maybe sometimes even 4 cc's of bone. That's quite a lot of bone. So you need to be prepared for that and have everything available. This is a transalveolar approach, where the membrane, the Schneiderian membrane, is lifted with an osteotome. This is fairly unpredictable, and you need to know exactly what you're doing here. It does work, but you need to know the technique very well, and you need to have some loop-back safety mechanism that you go back and check, so that you realize you haven't created a perforation. And here they've actually filled that with performed this, so you're getting between 4 and 6 millimeters, and it's not recommended for more than that. That's pretty much it. So I usually find if I place 6 millimeters, I'm probably going to get an absorption of 2 or 3. So you need to be wary of that. If I have sufficient bone and I'm maybe protruding 1 or 2 millimeters into the sinus area after lifting, that's far more predictable, because I'll still put that amount of bone, knowing that I have a barrier of about at least 4 millimeters above my implant. Periodontal defects we are not going to go into. So look, without further ado, that is where I'm going to leave it. The periodontal defects, ridge augmentation we covered last time, but a lot of these procedures are far more complex procedures. So it's not something that I want to really entertain in this type of webinar. This is something that's far more important to deal with when you actually have the experience and everything else that you need to know before you start doing things like that. As I said again, I think it's important for you to get experience. Come and observe, come and have a look. All you have to do is contact us. As I said, the number is 02-8070-9010. It's on our social media. You can ring the practice, just look up Dr. Babu Choker Clinic and give us a call there. Come and have a look at procedures. We do multiple types of procedures every week. Everything from simple immediate replacements, socket preservations, all the way through to full mouth rehabilitations, sinus lifts, simultaneous placements with sinus lifts, and full mouth rehabilitations with bilateral sinus lifts, augmentation, and bone grafting. I hope you've enjoyed this second part, and I hope it's been informative. As I said before, please follow us on Facebook, like us, share with as many people as you can, because we're trying to build a community, and the bigger community we have gives us the opportunity to carry on doing these free webinars for you. Also, follow us on and like us on Instagram, and please get in contact. The boot camp, we will send out details for that very soon. And we'll be advertising that. As I said, it'll be the first weekend of February. There'll be a 2-day event, 12 hours CPD. I'll be doing demos on everything for if you want to start implanting your practice, and if you've been placing a few, you're placing implants, but you want to revise all the principles and get things so that they're of a high standard. It's for you too. For people that are experienced implants, you want your associate to come to it, you want to bring staff members. A number of people have inquired whether they can come and bring their nurse, because ultimately they're going to be involved in setup and assisting you. Just as important, come to the boot camp, and you're getting 12-hour CPD, and you're getting that for $300 if you bring a friend. Also, as I said, we will be sending out, and we're open. I think next week we start registration for the certificate course, which is, and just to remind you, it's modular. So you don't have to do a 3-year MSc. Quite often, a number of our candidates will come and do a 1-year certification, and they'll go away and they're happy, because they will basically start placing implants, really be able to give patients what they need, enhance their practice and be happier, and also be remunerated for that properly. Some of the people like to go on and would like to go to the diploma level. They want to take on more advanced cases. And some people want to actually come back and they want to do the MSc section. It's part-time, so you don't have to spend a lot of time out of practice. It actually takes a very low toll for you academically and otherwise. There aren't exams and things. There's just forms and stuff you fill out. Is mainly reflective, which is what dental council prefer. We've tried to, and the General Dental Council in the UK as well, and we try to gear it around that. So you've got that, it's evidence-based, and it's something you can quite easily do while still practicing, and really enjoy your dentistry. I look forward to seeing you next week, and until then, stay safe and take care. I see you soon. Bye-bye now.